All right, if you are suffering with a back injury, chronic back pain, and you have been told that you've got a bad disc, a herniated disc, a bulge disc, an annular fissure, degenerative disc disease, then this video is for you. So in this video, I'm gonna walk you through how I think about chronic disc pain, chronic back pain that's related to a disc. And I'm coming at this not just through the lens as a clinician, as somebody who helps patients through this, but also as a chronic back pained person. I herniated 2 discs a little over 10 years ago, and I have struggled up and down over the years with back pain. And I'm gonna talk to you kind of about how I think about this, how I have treated it in the past, kind of how I have progressed over the past 10 years. But I'm gonna focus heavily on the disc-centric model that I have currently adopted over the past few years that seems to be working a lot better for our patients and for myself. So when we have a scenario where we have a damaged disc, Stu McGill has talked about this a lot, where we have now lost spinal stability. You've got one vertebra, you've got a disc in between, you've got another vertebra, and when you have a nice intact disc, this is really stable. This moves together and it is not wiggly wobbly in medical terms, but it's not unstable. When we start to have damage inside the disc, where the disc loses integrity, what happens is we get micro instability. This is not large macro instability where, you know, if you took a flexion or an extension x-ray, that you would see an actual shifting of these bones on each other, what would we call an antero or a retrolesthesis. But we have this micro instability where the 2 vertebrae are moving just a little bit, and it's enough to irritate not just the disc, because the disc is now going to be more innervated from the injury that's happened, but it can also have consequences on other structures in the back. The big ones are going to be the facet joints. The SI joints will sometimes take the brunt if they're kind of a little bit overworked, especially when you're down at the L5-S1 level for a disc injury. But really, it's the facet joints that are going to take a lot of the brunt. And so what happens is people get this disc injury. Now they have this micro instability, and over time, the facet joints just take a beating. During that process, the facet joints now become painful. They might become arthritic. You might get some cysts or some other things with it. And now somebody has, you know, more what people might call mechanical low back pain, which I'm not really a huge fan of that term, mechanical low back pain, but it just means that we have back pain coming from something that's actually present in the back, such as the facet joint. So facet joint pain tends to be worse when you extend. It might be worse if you lean to the side, and if I'm leaning to this side, it'll hurt on this side. Lean to this side, it'll hurt on that side if that's the side with the problems. Twisting and arching is really problematic with facet joints, and it tends to be better when we sit down. And so somebody might come in and present with this, and this is what I had for quite some time, where it seemed like my facet joints were the cause of my pain, and they were. The facet joints were painful, and for many people, they are painful. But if we want to take a step back and we want to say, what is a deeper root cause here? A lot of the times there's an underlying disc injury that is resulting in micro instability that is causing these facet joints to continually just get beat up day in, day out, and then they become painful. These patients generally will have, this is what I had, just kind of low-grade chronic low back pain that's present all the time, but it's not really enough to do much about it. It's just like, at the end of the day, it's kind of achy, sore. But then sometimes it's every 3 months, sometimes it's once a year, sometimes it's once every few years, we tweak our back and now we're down and out for, you know, 3 to 6 weeks, sometimes even a little bit longer. And that's the cycle that I started to get in about 2 years ago, after a long stint of basically pain-free that I had from a stem cell procedure I underwent. But I got back into this rut where kind of every so often I'd tweak my back, I'd be, you know, I wouldn't be able to go to the gym for 3 to 4 weeks, and I would just kind of cycle in and out of this pain. And really what it comes down to is these little they're not micro, these injuries that are occurring with some form of frequency are new injuries to the disc. It's that usually an annular fissure, which is a tear in the outer aspect of the disc, where that gets painful And with these, the micro movements that happen, then you get something a little bit bigger, and now you get a re-aggravation of that. And so our approach now, when we're working with patients, and this is the approach that I have adopted, is it is vitally crucial to actually treat that disc. Now, that doesn't always necessarily mean that we're doing injections for the disc, what's called an intradiscal injection, which we're generally using high-dose leukocyte-rich, platelet-rich plasma. But we have to treat it in some fashion. And so sometimes we will just start with getting somebody in with a good physical therapist who understands really well how to help improve good, true core stability, such that the core can now brace properly, which takes load off the disc. That's definitely route number one, and that's almost every single patient we are going to be recommending that they're in physical therapy to better learn how to brace their core properly, which is not just flexing down, it's actually increasing and creating intra-abdominal pressure. That is crucial. And then if that's not providing relief, or if we want to do this in conjunction with injections, our approach then is going to be fluoroscopy guided or x-ray guided injections into the disc, where we're using a high dose leukocyte-rich, platelet-rich plasma. Now, when we treat the disc, we are not just thinking about treating the disc, because as I've already talked about in this video, this is a disc-centric model, but it's not just the disc that's problematic. You also have facet joints that are irritated. Most of these patients have multifidi muscles that have atrophied. Oftentimes the iliolumbar ligament is a little lax or could be contributing to some pain. The interspinous and the supraspinous ligaments are part of the functional spine unit that help to stabilize, each vertebral level. And so our approach is comprehensive. We look at treating the disc. If the facet joints are painful, we treat those. We might treat the capsular ligaments of the facet joints to help provide some stability. If there's a little bit larger instability that's present, we're treating the multifidi for the atrophy. Sometimes you have to treat the SI joint depending on what else is going on in the case. Lumbar ligaments are a common thing that we're evaluating for and potentially including our treatments, and then those supraspinous and interspinous ligaments. Our approach is the regenerative methods. These are the orthobiologics. This is the platelet-rich plasma. This is the bone marrow construct. This is the adipose tissue transfers or adipose stem cell therapy. Our goal is to reduce inflammation, maybe help repair some tissues. The jury is still kind of out on, how much tissue repair actually happens with these injections. The research hasn't shown a whole lot, but then again, there actually hasn't been a lot of good research on this topic. But what we do know is that we are seeing improvements in function. We are seeing improvements in pain. We are tracking our patients, so we have the data to actually prove this, that our approaches for patients who have chronic low back pain, whether it's from a disc or not a disc, where this video is talking about discs, that we are actually seeing improvements in pain. And so that's how we think about this. That's how I have approached my my disc pain. I'm now about 4 months out from my intradiscal procedure. I had my L4-5 and my L5-S1 discs treated. I'm now back in physical therapy. I'm doing strength training, and I would say I have some minor aches, maybe 2 days a week, and it's about a 1 out of 10 when that happens. That is a whole lot better than what I was before my intradiscal procedure, where I was on average on a daily basis, a baseline 2 to 3 out of 10 every single day, with mini spikes throughout the day, upwards of kind of 5, 6. And so it wasn't excruciating, but it was enough that I needed to do something about it. So I hope you found value in this video. I hope if you have chronic back pain and you've made it to the end, that you have learned something here, because that is our mission here, is to help educate you so that you can live a better life. See ya.